by itself, you can suspect sleep apnea, but you really need a sleep study to actually diagnose among those children who have sleep apnea. We are more in the focus of treating reactive medicine.
Christian, give me no. Describe the first 8 children with obstructive sleep apnea. It was a symptomology. The total apneic episodes, yes, it's there. It has to be there. On this left side, the patient has what is called empty nose syndrome, atrophic rhinitis. So yes, you have a big gaping hole, lots of space. The patient can't feel air. I mean, you see a guy like this trying to do myofunctional therapy, and the tonsils are just all over the place. I mean, these things have to go. Okay, you can't myofunctionalize yourself out of this.
Good evening, everyone, and welcome. I am Lauren Gates, your host of our Airway Health Solutions conversation, featuring Dr. Umakanth Katwa and Dr. Stanley Liu. Tonight is a very exciting topic. It's pediatric health prevention from day one, and we're coming straight off of Airway Palooza, where we're kind of fired up about this because we literally had 20 hours of reviewing downstream disease and really the potential we have to prevent it all the way upstream. When I say all the way upstream, we even went prenatal. So we're thrilled to have you, Dr. Katwa, Dr. Liu. Thank you for joining us this evening. We're looking forward for you sharing your wisdom. And I wanted to welcome all of our listeners, because without you, we can't be possible. So as long as you guys keep showing up, so will we. We have close to 500 people registered this evening. So again, this is of most interest. And I know that this particular episode will be reutilized for lunch and learns with pediatricians all throughout the local, everyone's local collaborative type of circle. So we're really excited for this to be repurposed, used for lunch and learns, and people can reach out with any questions that they have. But I always like to get a feel for who's in our audience this evening. So why don't we go ahead and take a poll and see where everyone is, not from, but what profession everyone is and where everyone's at. So let's go ahead and roll that poll, Jay. So please choose the best description to describe your profession. Okay, we have 60% participating. The dentists tend to win this contest. And so I need to add pediatrician to our list, because that's, we'll see if, we have other healthcare professionals, medical doctors, 2%, but you can see we have a large amount of dentists, dental hygienists. Always nice to have everybody here. So if we don't have your profession listed, can you kindly put it in the Q&A session? You can put in the Q&A, because we'd love to acknowledge everybody. So thanks for joining. And let me just see the final poll here. There we go. Okay, so we have a little bit of a mix. And then, as I said, this is going to be utilized for lunch and learns in the pediatric community. So welcome, Dr. Katwa. Welcome, Dr. Liu. I know we're just coming fresh off of Palooza. And Dr. Katwa, why don't you just kick off a little bit of the interest here? As you see, there's mainly a dental audience, dental focused here. Why don't you share with us why you're excited to be with us this evening to share what you know?
So thank you, Lauren, for having us. I always love working with you and Stanley. I think we've been going a long way. So as I've been treating sleep apnea for a long, long time, and I see more and more people joining the club of having sleep apnea. So I started wondering, what's happening, and are there early signs? There is a huge push for preventive medicine as such in medicine. I said, is there a way we can at least identify early or prevent it, or minimize the burden of the disease? And I started looking backward, and really took me to the journey, which I was really surprised myself, because I was not trained to think that way. I was just treating the diseases. So I thought, this is a good way to make people aware. I think awareness is half the treatment. People, if you're not aware, you don't see, you don't think about it. So, and then coming the awareness, not only in the people like the regular kids, but also people before the pre-disease model or the early disease model, and try to minimize the impact of the disease. So that fascinates me. And I think people who are here today, I think the dentists, the physicians, the pediatricians, and the myofunctional therapists invariably touch those early childhood, some form and shape. And those signs could be the subtle signs or the early signs are a predictor of future airway issues. So I think it is fascinating, and I really wanted to, share my thoughts.
We're thrilled to have you here. And Dr. Liu, it's so interesting because, Dr. Katwa sees, life, the first hour, and here you see the downstream disease. So it's such a nice bookend here of different perspectives. And the great news is that this is all preventable. So why don't you share from your standpoint why you're with us this evening on your own free will?
Yeah, thank you both. There's only so much that we can do for patients with sleep disorder breathing once they're adults. And one of the most other important things is, even if we're able to treat sleep disorder breathing in adults, all the damage, let's say, right, all the negative health related impact has already occurred for so long leading up to it. And so my hope, of course, is that the lessons that I learned from anatomy, functional anatomy, and then tracing it backwards to really restore these missed milestones, or even better, let's just not miss these milestones to start with. So I appreciate the opportunity to share my perspective.
Thank you. And I want to share that we just announced yesterday by a press release today, welcoming Dr. Katwa and Dr. Liu to our faculty, and we're thrilled to have you. So welcome as faculty members to the AHS Conversation Series. This is going to be wonderful, and we'll talk about your upcoming coursework after. Just some housekeeping notes. We do have a raffle plan this evening, so you do need to stay to the end, and we're going to raffle off our Pediatric Airway Health Fundamentals course. So that's about an $800 value. So stay tuned for that. And also, to receive your CE certificate, you must be in attendance for the entire program. Zoom software tracks the attendance, so there's no code or there's no survey. So you just be there to the end, and it usually takes about a week to get your CE in the mail. A few disclaimers to share is the views presented are the opinions of our speakers and are not necessarily affiliated with Lauren Gates and Associates and Airway Health Solutions. And the following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health providers regarding a medical or dental condition. Okay, so we got that covered. And I'm going to go ahead and introduce Dr. Katwa, who's going to give us about a 20-minute presentation or so from his point of view on warning signs and prevention. And then Dr. Liu, it'll be my pleasure to give you a formal bio, and then you can share with us your presentation. And then we have plenty of time for Q&A. So it's my distinct pleasure to introduce Dr. Umakanth Katwa. Dr. Umakanth Katwa is a pediatric pulmonologist and pediatric sleep specialist and director of the Sleep Center at Boston Children's Hospital and assistant professor of pediatrics at Harvard Medical School in Boston. He did his fellowship training in pediatric pulmonary and sleep medicine at Harvard University in Boston. He is the director of the Infant Apnea Clinic and co-directs the multidisciplinary sleep apnea and sleep surgery program. He has extensive teaching experience and co-directs pediatric sleep medicine courses at Harvard and Tufts University. He is a member of the American Academy of Sleep Medicine and the Sleep and Respiratory Technologist Education Task Force. His research interests include phenotyping, pediatric OSA, infant sleep apnea, drug-induced sleep endoscopy, and technology integration and sleep evaluation. His current NIH-funded research includes AI-based modeling of sleep study interpretation of pediatric OSA called Complete Artificial Intelligence-Based Sleep Report and quantitative retrospective analysis of sleep physiology. He lectures widely across the world and is involved in teaching sleep physicians, dentists, and medical students. He is extensively published in several peer-reviewed national and international journals. So it's my pleasure, Dr. Katwa, to welcome you as faculty member and to give you the floor with your wisdom. Take it away.
Thank you, Lauren, for the kind introduction. So I have 20 minutes to cover a topic which I can talk for days, and my recent passion is about how we can minimize or prevent this thing. So nevertheless, I thought this may be a good way to give an overview of how to think about. And remember, I'm just talking about a small aspect of this prevention. This is no way complete. So I may miss, because of the lack of time, some aspects of this, but I think we will be able to cover in future some other time. So this is a university. So let's talk about, like, before I go into the sleep apnea, like, what is that we are talking about? I think you know about this and you've heard about it in multiple forums, but I thought let's talk about the definition of sleep apnea. So here is a child who basically came to one of the hospital, actually came to the emergency room. You can see the kid lying in the emergency room. And mother thought this patient was having some respiratory distress. And you can see this patient is mouth breathing, having retractions of the chest. The mom thinks the kid is like a serious respiratory issue. Ultimately, it turned out that this patient had sleep apnea. There was nothing wrong with the respiratory system or a viral infection, because as soon as the patient woke up, it was totally fine. So keeping that in mind, how do you define sleep apnea? Sleep apnea, or the obstructive sleep apnea, is a highly heterogeneous systemic inflammatory disorder of dysfunctional breathing during sleep. So it could be not necessarily apnea, it could be hypopnea, it could be shallow respiratory effort, it could be complete obstructions, or a prolonged partial upper airway obstruction. So it could be a various form. So sleep apnea is one type of dysfunctional breathing. It has recurrent episodes of partial or complete airway obstructions, and the essential feature is a narrow airway or increased upper airway resistance. And this is the definition by the International Classification of Sleep Disorders for children less than 18. They should have at least one of the following: either snoring, obstructive breathing pattern, if they have a video or some of the descriptions by the parent, or daytime sleepiness, tiredness, fatigue, or some impact of the sleep disturbances on the daytime. And then if you do a sleep study, you typically have an obstructive apnea index of 1 per hour, or if you don't have an apnea or you have obstructive breathing pattern, you have an elevated CO2 of more than 25% of the time, more than 50. So by itself, you can suspect sleep apnea, but you really need a sleep study to actually diagnose among those children who snore who have sleep apnea. So why do we care about it? So why are you so worried about, like, identifying and treating sleep apnea? I think sleep apnea is one of the preventable cause of many, many downstream effects, which can include cardiovascular, metabolic, endocrine, neurocognitive, and nocturnal illnesses for that matter. The most important from a pediatric point of view is neurodevelopment or neurocognition. To optimize the health of a child, parents are concerned that my child has to have the best ability to grow and develop into a very productive individual. Nowadays, we see a lot of ADD or ADHD. We have children who have difficulty staying awake and they're falling asleep in the class or other places. Poor concentration, poor school performances, poor memory, and ultimately having a lot of neurocognitive disorders. And that is when your early childhood brain development is happening, and disordered breathing during sleep, which can start even on day 1 of your life, or in some children can start around 1 to 2 years of age, can progress until the time it is diagnosed, which can be several years, and then subsequently treated. Even a 2 to 3 years of exposure of sleep disorder breathing in various forms can have lasting impact on the neurocognition. Hence, it's important. So in addition to this, if it's left untreated down the line, you can have cardiovascular dysfunction, endothelial dysfunction, hypertension. It can have dyslipidemia, insulin resistance, high risk for diabetes, and eventually other cardioendocrine issues. So now let's talk about the risk factors. So is this entity preventable? Is this entity identifiable at a point in time early in your life? If you look at it, let's start from the birth, right? Even before the birth, you know that during pregnancy, a person gains weight, and as the baby grows, and there is a risk of sleep apnea which increases. So it has been postulated that about 10 to 20% of the pregnant women develop sleep apnea, more so towards the 3rd trimester, which is around 20%. If you have underlying eclampsia, if you have underlying diabetes or obesity, in addition to this, the risk almost doubles. So what happens with pregnancy apneas? So the mother is prone for having sleep apnea, whether it's mild degree, moderate, or severe degree. It leads to intermittent hypoxia, leading to further hypoxic exposure to the fetus. It also increases the autonomic stress that eventually, over a period of several months in gestation, can affect the epigenetics or the gene expression of the patient. It can have impaired fetal functions such as suck and swallowing, fetal breathing, and also fetal movements. It can also affect the fetal development, particularly craniofacial development and neuromuscular development. Ultimately, the growth and development can be impaired, can lead to IUGR. In addition to this, it can also lead maternal hypertension, lead to preeclampsia. Risk of premature delivery is increased in patients with obstructive sleep apnea during pregnancy. The most important thing during pregnancy, which from an airway perspective, are the fetal tongue movements. They're very, very important for developing the tongue, maturation of the tongue movements, and also important in suck and swallowing, which is a critical part of an breathing and airway development. It also affects the fetal breathing movements, which are happening from 10 to 12 weeks of gestation, continues to mature up until 34 to 38 weeks of gestation. It can also affect the craniofacial development of the children. So that can lead to a significant craniofacial dysmorphism, particularly children with the narrow maxilla, or they can have a small mandible. It can also affect the neuromuscular modulation, can lead to low muscle tone and other craniofacial disorders. You can see that about 60% of the craniofacial development is done by 6 years of age. In the first 2 years of life, your craniofacial development is at its peak. If there is a disordered growth during that critical period of craniofacial development, you are set to develop sleep apnea at a later date, and sometimes you can present with sleep disorder breathing or abnormal airway health even at a later date. In addition to this, it's also important the mode of delivery. There are certain postnasal factors. So vaginal delivery helps secrete oxytocin, helps contract the uterus, and also produces stress hormone, which helps to mold the your craniofacial structures and also exposes to the vaginal flora. This is extremely important for your gut flora and airway flora, and that has an impact on your overall health. Patients with cesarean sections don't have the advantage of going through this, and also technically are slightly higher risk of having airway dysfunction. In addition to this, if during pregnancy, the fetus is exposed to prolonged hypoxia, either because of perinatal issues, preeclampsia, placental abrasion, or hemorrhage, or any of those things, or poor contraction of the uterus, if the mother has sleep apnea, those pregnant ladies are at a higher risk of developing or having cesarean section. So because of the lack of the delivery or their lack of adequate contractions, they are at high risk of C-sections. In some patients, because of the preeclampsia is so severe that the pregnancy has to be terminated early. So they are at a high risk of premature delivery. Subsequent to this, in the postnatal factor, breastfeeding is an important factor. In addition to the breastfeeding, postnatal breathing. So babies who are born with high risk of perinatal hypoxia or at a higher risk of prematurity, at a high risk of immature breathing pattern. So your brainstem is getting mature, and the myelination in that area is optimum at around 38 to 40 weeks of gestation. If certain babies are exposed to hypoxia in the perinatal period or in the prenatal period, those maturation centers will take time, and those patients are at a higher risk of developing disordered breathing even on day one of life, particularly your central sleep apnea, periodic breathing, and sometimes they can have an obstructive breathing pattern in addition to this. That will take about I have seen babies in my clinic which take up to 6 months to 1 year to even resolve these issues. So it's very important. Coming to the early signs of airway challenges, can we suspect, will this patient be at a risk of developing airway issues? It's not 100% that it is always these patients are developing airway issues, but if you see patients who have low APGAR scores are exposed to hypoxia in the perinatal period, and the APGAR scores are given based on the respiration and the cry at birth, your neonatal reflexes and irritability, your heart rate and pulse rate, skin color and muscle tone. So if these are reduced, it can or mark as a sign of perinatal hypoxia. And the hypoxia can be just before delivery, or the hypoxia can be happening for a long time in the utero. Those patients are also at high risk of developing poor feeding pattern or poor latch. If the baby has difficulty feeding, and those patients, and in spite of giving good lactation support and they are struggling, you may suspect that there may be a possibility of this child may develop some airway issues. It could be because of tethered tissue or low muscle tone or various factors, but that should be suspected. Difficulty feeding because suck, swallow, breathing are coming from the same respiratory centers in the brainstem area, and a defect in one, like feeding difficulty, one should always suspect that there could be a breathing difficulty in those patients. Frequent desaturations while the baby is monitored in the NICU, or sometimes if there is an obstructed breathing right away because of retrognathia, pulmonary atresia, laryngomalacia, you can start hearing the noisy breathing from day one. And again, these patients are at a higher risk of developing sleep apnea. And mouth breathing, if you see in a baby, it should be taken as an early warning sign. Babies are obligately nasal breathers. They are designed to breathe by the nose. And if you see a baby mouth breathing on day one, you really have to suspect there is an airway obstructions or there's something, an airway dysfunction, which can manifest later in day. And this is the immature breathing I talked about, which is a combination of neuromuscular issues, brainstem issues, peripheral chemoreceptors. They are maturing over a period of time, and various centers are playing a role and ultimately causing stable breathing. And you can see this is the baby who had a sleep study because of desaturation. You can see this baby is having respiratory effort, no effort, respiratory effort, no effort. This is your classic immature breathing pattern or periodic breathing. It may indicate that the baby is premature, or the brainstem is premature, or there is some perihypoxic injury to the brainstem. And these patients are at high risk of intermittent hypoxia, and if you don't identify and treat, it can affect neurocognition in a very early stage of development. And it's very, very critical to suspect this, screen these babies and treat them. And if you see the baby mouth breathing from day one, I think, as I mentioned, it is an abnormal consideration. So what are the early signs? The early signs important, it really involves a careful examination of the baby right from birth and subsequently in the pediatric offices on a monthly, 3 monthly, or 6 monthly, and keeping an eye on this development. If the baby has an overall low muscle tone for various reasons, either syndromic or non-syndromic, they're at a high risk of sleep disorder breathing. If not now, eventually they may become obstructed airway or glossoptosis. If they have a retruded mandible, again, it can be very subtle at times. You can see here the lip is slightly behind, or it could be severe in patients requiring surgeries. Those are at high risk of developing sleep apnea. Tethered tissues, tongue ties, lip ties, which can affect the mobility of the tongue and ultimately impact your craniofacial development, are also at high risk of sleep apnea. If you see open mouth posture I talked about, when you pull the mouth down for a baby, if the tongue position is low, those babies are at a high risk of sleep apnea. But normally, if you try to just gently put a pressure on the mouth and try to open the mouth of a baby, you should see the tongue should be sucking or attached to the upper palate. If that does not happen, so they could indicate that these babies have low tongue muscle tone. Babies with high arch palate, baby with cubic bow-like lips, they're at a higher risk of developing sleep apneas. And sometimes when the babies cry, you can see like a hollow spoon-like tongue. And those babies are at high risk of developing sleep apnea. Or when the babies are breathing, normally the nares should not be flaring. But if you see the nares are expanding every time the baby is breathing, it may indirectly affect that the baby has a compromised airway or airway obstruction, which needs careful evaluation and treatment. In addition to this, I pay attention to the neonatal reflexes, which gives you an idea of maturity of the nervous system, can also help you to understand that if there is anything which needs to be taken care of. So those aspects which I mentioned, if left over a period of time, right from pregnancy point of view, during pregnancy, during delivery, and after delivery, which include breastfeeding, the diet, the environment, the microbiome, the way the baby is breathing, the baby is feeding and growing, it really ultimately determines how your airway anatomy develops, which includes craniofacial and soft tissue. These can have a certain airway phenotypes of sleep apnea. If your muscles are abnormal, they're not completely mature, they're at a high risk of myofunctional disorders. If your skeleton is not supporting those muscles, higher risk of airway collapsibility. Ultimately, those patients can have pituitary issues. Arousal thresholds can be affected because of your abnormal gene regulation of autonomic system. Ventilator and chemoreceptors because of intermittent hypoxia. It can create increased sensitivity and high loop gain. And ultimately, poor muscle recruitment for various reasons, hypoxic injury or whatever it is for a period of time, can lead to various phenotypes which actually present at a later date in life. So hence, how do we do this? This is a possibility. This is connecting the dots. This needs a lot of research to actually connect the dots. We have done research in silos, and we know each aspect can lead to sleep apnea, but it is very difficult to have a baby with retrognathia and monitor them until they develop sleep apnea. Nobody does those kind of studies, but we have enough data to show that individual entities of those can cause significant sleep apnea. So hence, the education should start during pregnancy. Awareness of sleep apnea during pregnancy is very critical because it's quite common. And we should assess, evaluate, screen, and treat sleep apnea. I think overall optimizing the maternal health for the well-being of the baby and the mother is extremely critical. And I think in this day and age, when people are working and stressed out and the diet is not optimum, that is one of the easy things to forget. These ultimately will prevent preterm labor, also prevent preterm labor and treat them effectively. There are, again, I did not go into the details about assessment in utero. That's a whole different topic. We can do assessment of the baby's jaw, growth, craniofacial structure. Ultimately, we can also assess the baby's tongue motions and suck and swallow motions by ultrasound can be an indicator that how the baby is developing, not only from a craniofacial perspective, but also from a neuromuscular perspective. We should avoid C-section as much as possible. So I think by identifying these targets, I think by at least understanding this and try to intervene as early as possible, I think eventually we may reach a point that, like a newborn screening, we can identify a newborn screening that we can easily do this right at birth and subsequently every 3 months in pediatrician office and early intervention. So if you want to do something, we should also have an intervention for that screening so that just identifying that is not sufficient. So in my opinion, you identify the risk factors, monitor the risk factors, early intervene the risk factors to the point that at the pre-disease model, you intervene so that you can actually prevent sleep apnea. It's a possibility I'm thinking these days so that we can implement this at a much national level and see the impact of sleep apnea and the morbidity and mortality related to airway, which I think is easily preventable in many, many healthy kids, can be achieved. Thank you.
Thank you. It's really fascinating what we can do from day one. I know the Children's Airway First Foundation, we're all board members of them. They're putting a lot of effort into this. But Dr. Katwa, if I can ask you, why aren't we doing this? Like, what are the barriers? Like, why isn't this happening? Is it lack of awareness on the academia side? Help me understand. It seems so logical to do this. What is the counter position?
I think it's an excellent question. And I think I will take my own example and tell you where it stands. So I work and breathe sleep apnea. So I've been working in this field for the last 15 to 20 years. And I've been researching in this area because I was, like, as I told you, in the last 3 to 4 years. And I think when a person like me who is in the thick and thin of this just knows this for the last 2 to 3 years, you can only imagine who people are not working in this one. So I think how we connect the dots, we are more in the focus of treating reactive medicine. I think we've been into the preventive and proactive medicine. And unfortunately, the healthcare system doesn't reward, help, or pay. If somebody comes to me and I try to treat them, I may not be able to code them for a disease because this is not a pre-disease model. I cannot bill them. So unfortunately, part of that is economics. Part of that is, there are so many sick people, like we need to take care of them first. And you don't come back to me until you are sick attitude. And third is a lack of awareness, are able to connect the dots.
Well, thank you for helping to change that. I know that every voice matters. So, and we have a nice group of people today that can have the ripple effect and share with their pediatric specialists and their communities. So thank you so much for that. We'll do a general Q&A session after Dr. Liu is completed with his portion of this program. So I'm going to go ahead and introduce Dr. Liu, and Dr. Liu, you can get your presentation ready while I do so. Okay. Dr. Stanley Liu is dual trained in oral and maxillofacial surgery and ENT sleep surgery. His work bridges dentistry, medicine, and sleep science. He serves as chair of oral and maxillofacial surgery and director of the Breathe and Sleep Wellness Center at Nova Southeastern University. Formerly on faculty at Stanford University, Dr. Liu updated the Stanford sleep surgery protocol and helped define the contemporary surgical approach to obstructive sleep apnea. A past keynote speaker at the American Academy of Sleep Medicine and the World Sleep Congress, he has lectured globally on airway surgery, interdisciplinary care, and the future of sleep medicine. With over 100 peer-reviewed works, his mission, innovation by integration, focuses on restoring sleep breathing health as the gateway to wellness. And we're thrilled to have you on this evening. So thank you, Dr. Liu. Go ahead and you have the floor.
Thank you, Lauren, and thank you, Uma. Uma, while you were talking, I had a chance to look at our Zoom, participants, many familiar names, a lot of whom are absolute experts in this field. So I really look forward to your feedback, staying in touch, and of course our collective effort, right, to really change the course of how we see sleep disorder breathing. Uma and I have been at this for a long time. I mean, we could do this on Zoom and live. We did one of the earlier pediatric dental sleep residency programs to really bring this to folks' attention. I think I see a lot of the students in this picture have gone on to start their own courses and create ecosystems of care in the United States and beyond. So I'm super proud of it. And our students are doing so well that Uma just can, take a rest now and not work so hard. And of course, we're really also piggybacking on just the enthusiasm and the direction that Airway Palooza had brought about, and this year with my mentor, Dr. Klee Kushida from Stanford Sleep Medicine. I love this quote. This is a very, very telling quote from the guy who started it all, right, Dr. Bill Dement. And he writes in this book, right, as late as 1970, the practice of medicine ended when the patient fell asleep. And it's entirely true. We have no idea what happens to people when they're sleeping. We have no idea what happens to their brain, what happens to their breathing, to their digestion, to everything. Okay, and this was an era, right, in 1976 when someone had to come out and convince people that children also have obstructive sleep apnea, right? And if you think about it now, of course, given the audience we have here, many of you are very enthusiastic and are well aware of this. Just remember that in 1976, someone had to come out right and prove this. Now, the narrative isn't as interesting today, and this is why we'll go back to history in just a moment, because invariably we are oftentimes struck with these simple AHI numbers to diagnose what is either pediatric or adult sleep and the severity of which. And I often joke about the fact that there are plenty of teenagers taller and bigger than myself, and in this part of my career, a lot of adults who act like children. So this is not going to, these AHI numbers are not going to tell us a whole heck of a lot. And it did not begin this way. It did not begin this way. When Christian Guilleminault described the first 8 children with obstructive sleep apnea, it was a symptomology. The total apneic episodes, yes, it's there. It has to be there. But it's a symptomology. And if you look at it, it's daytime somnolence, snoring, enuresis, decreased school performance, morning headache, mood behavior, weight change. And look at the weight change. It is not the obese child, right, that you want to be alarmed with at first. It's the not growing child, the not thriving child that's really struggling. And yes, and outright hypertension, not great, right? So let's just remember that when we address our patients, right, with this constellation of symptoms, the AHI is not it's something we need to note on the continuum, but the symptomology is really key. I highly recommend reading through this paper. Papers back in the day are very interesting. They even tell you the kids' hobbies and what sports they play. And I mentioned that because 2 of these 8 kids ended up having a tracheostomy as treatment. Remember, this is pre-CPAP, pre-oral appliance, pre-expansion, pre-myofunctional therapy. So all the great things we're going to talk about in this upcoming course, they didn't have it, okay? I also think one of the most telling things about kids, we're not going to exactly worry about diabetes just yet, right? But the fact that sleep disorder breathing or even snoring, even just parental reported snoring, all right, is associated with cortical thinning in children's brains. And a lot of this is concentrated in the frontal cortex, in the prefrontal cortex. And if you look at where it affects things the most, you'll see attention, right? The parts of the brain that is associated with attention has the most deficit from, a pediatric sleep disorder breathing. And yes, this is my other bad joke, but while we all say that we only use 10% of our brain, it really is just not a good idea to lose any brain matter over things that we really can address early on. So I show this all the time, and I still think this is a very good picture of, earlier on we were talking about, well, why isn't this message out there enough? A part of the reason is Western medicine is very cross-sectional in nature. So you look at the 8-year-old with ADHD, malocclusion, Reese's school performance issues. You might see the 40-year-old who now has OSA because he actually got a sleep study, hypertension, and because the original issue may be being kicked out by a bed partner. But this really is also the same patient, right, throughout life. Where these conditions were not addressed. And if you agree with that, then you can go back even further and go back to the 2-month-old with the trouble feeding, with the frequent URIs and the very noisy sleep, one of the videos that Uma has shared before. So unless we begin to look at this like as if this is one patient rather than 5 different patients, we're not going to be able to share our needs with our collaborating medical health professionals. Now, yes, while I have, I think, a well published and well shared protocol with adults, I pretty much have this version just backtracked the missed milestones to a pediatric model. Let me come back to the other slide. So when we do the course, again, I'm not saying this is the way to treat. I'm just saying that this is a way to think about everything on a continuum, and at a place where if a patient were to miss a certain part of the milestone, that we can restore it, etc. And so we'll go use that as a framework. I do share this because this was the keynote that I had kept on the World Sleep website that describes the adult protocol. So if you kind of capture that, and then you can see all the horrible things that happens when you're an adult with sleep apnea, then we'll come back and look at things that are a little bit more positive. Okay. So, we'll look at a lot of endoscopy. These are sleep endoscopy images. What are we in the business of treating? We're in the business of treating of either collapsibility, if you will, in older folks, or more like obstruction in pediatric cases. And it's not just the soft tissue collapsibility or obstruction. It's also an airflow problem. And in a child, for example, here, it would manifest more like tracheomalacia, okay? So I say we're in the business of treating floppy tissue and airflow, okay? And bottom line is we don't want collapsibility. We want the same person, right, with a much more stable airway. It takes a lot more negative pressure to collapse. Now, a child is not going to collapse like this over here with this image on the left side, but we have to remember also that there's effort. So if it takes a lot of effort for folks to keep their airway open like this, they're going to have very disturbed sleep, and they're going to be very symptomatic. Towards the end of CG, Professor gave me notes, life and career. He was very adamant about sharing some of these ideas. Now, he's no longer by this stage able to publish in this is not a randomized controlled trial, New England Journal type paper, but he put out a series of things that I think has continued to drive the field. One of which is towards the restoration of continuous nasal breathing as the ultimate goal in pediatric OSA. Okay. And I believe that. And I'm going to actually, I'll share this one here first. You'll see this is sleep studies where a person could, starts with nasal breathing, then goes into oral breathing. And when you convert to oral breathing, you have all the respiratory arousals. Okay. So you're waking up when you're mouth breathing, right, in this situation. And when we think about, so here's the thing, right? There's a lot of debate and things. And so I want to keep it pretty simple. I hope we can all agree that there are two ways to breathe, either through your nose or through your mouth. Okay. If there's another way, you let me know. We're not fish. We're not, snake. And the other thing is we have this struggle while we're awake, or some do, some don't. But then this is entirely different when someone is asleep. Okay. So when we talk about this internal nasal valve, highest resistance in the nose, yes, all true, but it's addressable if you're only talking about the awake state. So you can address turbinates, you can address septums, you can address upper lateral cartilage collapse with spreaders, but this is all when the patient is awake. And it is inadequate. It is inadequate in patients who have the narrow high arch shaped palate. But how do we know that? How do we know that, right? How do we do this study when we did this study with Ryan, right? How do we know these patients had this issue? Because the patients told us, right? This is the nose score. And we were able to note that the patients who had nasal surgery, who still feel like they have nasal obstruction, well, what's different about them, right? And that's how we were able to then prove that by expanding in a transverse dimension, that we were able to effectively help a lot with nasal breathing. So, through the course, we're not going to talk about, who's supposed to do this, how to do it, what to do, when to do it. There are many courses that goes through that. But just let me share why we do this. Why is developing this nice, wide, dome-shaped palate for children so critically important? Okay, I'll skip this one for now. So yes, we do this, in children with relative ease, and you expand, and we've shown all the measurements and the symptomatic improvement that comes with maxillary expansion. Not a new idea at all, right? Not a new idea at all. 1975, and this is where it's very, very important, right? An orthodontist and an ENT surgeon got together to treat children with nasal obstruction with maxillary expansion. Now, 1975, I don't know, you look at a year like that, just to put things in perspective, that was a year when Jaws was released, Godfather won the Academy Awards, and Microsoft was founded, okay? So putting in perspective, 1975, they were doing this. For what purpose? For the following purposes. Now, if you look at this is really wild, right? So that means in a child, if you want to anatomically change something about their nasal breathing, right? With adults, I showed you, there are all these surgeries we can do. You're not going to do a septoplasty on these kids. I mean, in an extreme rare circumstance, right? You are not going to do upper lateral cartilage valve, grafts or whatever. So the only way for you to make an impact is via maxillary expansion. And that to me is wild. That's why I sometimes kind of also jokingly say so like, you mean like the nasal surgeon for children are the dentists? But think about it. What other way do you have to change that anatomy? But it's not just the anatomy. You look at a scan like this, and if I were to take a poll and ask you, which side of the nose does this patient struggle with more, the right side or the left side? Now, some people might say, well, maybe the left side is easier because there's a lot more open space. But in this case, it's not true, because on this left side, the patient has what is called empty nose syndrome, atrophic rhinitis. So yes, you have a big gaping hole, lots of space. The patient can't feel air. So it's not just the anatomy. It's not just the black space. It's the mucosa. And when we have an expansion of the maxilla, in order to have stable airflow and activate the dilator muscles, you can't tell me a few millimeters of expansion does all that magic. It's the nasal mucosa. And this is where, the magic of a lot of the work that you guys do is that in expanding the maxilla, with distraction, you are also creating more nasal mucosa, which is a true real estate. In this course, we'll throw in a little bit of AI element. It's everywhere. And in this case, nice studies where people took lateral steps to train to look at adenoids, to then quickly scan for adenoidal tissue with AI. Very, very cool. We'll look at some videos of adenoids being taken out. It looks as good as it smells, or it smells as good as it looks. I don't know which way it goes. We'll talk about tonsils. Of course, you can't do this without talking about tonsils. Great discussion about tonsils, right? Almost every paper begins, one of the main causes of pediatric sleep apnea are big tonsils. Well, wait a minute. Okay. We have to kind of think about that again, right? The real reason may be that you're not nasally breathing, you're mouth breathing, and you have persistently large tonsils, right? So it may not be the cause. It's the mediator towards a negative, cycle there. See, technically speaking, you kind of want to have your tonsils because the tonsils, the palatine tonsils, have shown to actually stabilize the oral microbiome later on in life. The tonsils are a huge reservoir of probiotics that you may need sometime down the road. So how do you reckon with that? I mean, you see a guy like this trying to do myofunctional therapy, and the tonsils are just all over the place. I mean, these things have to go. Okay, you can't myofunctionalize yourself out of this. Okay, but luckily, here's the thing. Classically, this is what I do. You do a total tonsillectomy. But for many years, folks have been doing these partial tonsillectomies, or what they want to call tonsillotomies. And the data in recent years, a year actually, in systematic review, is showing that when treating sleep disorder breathing, partial tonsillectomy or tonsillotomy, just as good, and way less pain, way less bleeding, and you get to keep your tonsil. So that may be a good way to kind of share with your collaborating surgeons. We will talk about the chat study just as a framework, right? The whole argument, early and tonsillectomy treatment versus watchful waiting, what does change and how does that impact how we think about sequencing of treatment? Just remember that we're doing anything soft tissue or imagine there are two big tonsils in there. It's still better if you have a dome-shaped palate. We'll briefly talk about hypoglossal nerve stimulation in children because they are approved for use in children with Down syndrome. Challenge being that you still cannot do them with kids with concentric collapse, and almost all of them do. I've had one of the rare exceptions, and this child, mom was a dental hygienist and had him expanded 3 times as a kid, and so he was actually a candidate for this when I got to him. So very, very, very cool. Again, like I said, towards the end of CG's career, he pushed this one out big time with the lingual frenulum in sleep apnea in kids. We'll look at cute kids having their lingual frenulum addressed. These are early cases, cold knife, Q-tip, thinnest needle, sutures possible. And this is actually, a lot of you guys know Saruj. She was the second fellow I trained. We really try to adhere to the most gentle and physiologic models that we can to treat this. This is a cool sleep endoscopy video showing before and after frenuloplasty. So you release the frenulum, tongue pulls forward, moves by itself, looks good. Bottom line though, better way to do a dome-shaped palate, get early myofunctional therapy, can go even as early as 2 years old. If you have a smart mom who puts raisins on the top of this kid's tooth and you keep reaching for it. And even better, start with breastfeeding. In this nice study showing that if you breastfeed for at least 3 months, the kids have much lower chance of having snoring and sleep disorder breathing by age 6. Bottom line, we want to establish nasal breathing that causes negative pressure that collapses upper airway muscles, and all of that supported by the jawbone. And therefore, if we don't catch them when they're 11, do a simple expansion, their tonsils normalize in size, posture great, symptoms great. We can wait until their 20s with anxiety, depression to do anatomic treatment, but now you need surgery. You need maxillofacial surgery, and patients would rather never undergo that. Or you can wait until their 40s with myofascial pain, TM joint resorption. Again, they'd rather not do that. Or you can wait until their 50s and do this, and now you need to do maxillofacial surgery and hypoglossal nerve stimulation because the tongue doesn't want to move anymore. And going full circle, Come age 55, the patient on the right still has sleep apnea. The patient on the left does not, right? And yes, we have all the tools, in treating this adult right here for sleep disorder breathing. But whatever that has happened already to the brain, to the rest of the body, that's unrestorable. And this is absolutely why we need to do all of this on the front end, and as front end as possible, rather on the than on the back end. Nothing like standing on the shoulder of giants. I'm just grateful to be able to share a lot of this knowledge from what I've learned from them and years of practice. And I really look forward to engaging with all of our AHS community. Thank you.
Wonderful. Thank you so much. It's really fascinating to just see all the research come to life, history come to life, and taking it forward and paying it forward. So thank you for you sharing this. We do have some questions, and if you'd like to ask some questions in the chat, please feel free to do so. Actually, the Q&A is for just the session. So if you want to ask your question, go ahead and put that in the Q&A. But there's a question here that I think would be really helpful for everyone in the audience tonight. When talking with pediatricians, we'll start with you, Dr. Katwa. What are the most important things you would communicate to them easily to add airway screenings and discussing this with parents? So how do we bridge that gap, coming from your point of view? You can just come off mute, Dr. Katwa.
So what I have realized is, if you tangentially or randomly go and talk to them about one or two screening, they always view with skepticism. Like, if you go and just say, hey, the tongue tie is important, try to look for it, or try to connect like tongue tie with sleep apnea, in its isolation, it may carry less of a meaning, provided that they have done some reading or attended a talk or a lecture where they are seeing a pattern and why this is important. I think somebody can be convinced if they buy into this rather than told into this. You can take, there's a saying that you can take a horse to the water, you can't make it drink. So I think if they can be exposed to some of the material, Lauren, you're doing short snippets of like what we are trying to do, and create an interest. And ultimately, the learning has to happen on their side. I don't think so for a physician who are into practice, you just cannot go and tell them to do this unless they are forced by the academy. So the other way of doing that is, the American Academy of Pediatrics or somebody makes this a mandate, like newborn screening is compulsory, like hearing is compulsory, they have to do it. Otherwise, it becomes a medical legal thing, then they are compelled to do it. But short of that is training them, exposing them. It's a slow process. Even for me, it's not easy. I spend a lot of time training them, talking to them. But they say that from their point of view, they are such a busy practice that they don't have time. It's always an excuse. But I think eventually we'll get there. I think the neonatologist have to be convinced, then the pediatrician, and then obviously the dentist, because they don't see the baby up until at least a year of age when the dentition starts appearing.
Thank you. And same question for you, Dr. Liu. When talking to pediatricians, what are the most important things you would communicate to them about easily adding airway screening and how to discuss with parents?
Yeah, I would say focus on the symptoms. Meaning, if you were to go in and say, I think my child has tongue tie, my child has the big tonsils, or so, I don't know, it may be difficult to immediately engage them, but discuss the challenges that you're having, or the behavioral symptoms, or any other issues that they're having, and really engage them first on that, and then see where they begin to their thought process, and then you may be able to then add, hey, listen, I think they're not breathing great when they're sleeping, etc. So I would just say that initially, instead of engaging them right away on a potential diagnosis, engage them on the symptoms, and see if you can be more aligned in the care that way.
Thank you. The local ENTs say there is not enough information on infant sleep studies to interpret what is normal amount of episodes while sleeping. Is there a study you can point me to?
I think the infant sleep studies I agree with that, because the criteria I use in AHI of 1, I don't use that criteria for infants. I use more than 5, because there's a lot of variation in normal breathing pattern in infants, and we cannot go by a typical AHI. It's an entire breathing pattern and the clinical symptoms in babies. Even the scoring criteria start appearing much more robustly in a child more than a year old. So below year one, you need to know somebody who's reading those studies are experts in reading infant studies. If somebody who's not expert, they are reading it, they will treat an infant study like an adult or an older study, and then they'll give you an AHI and it can be misleading. I have seen patients with a little bit higher AHI have not done anything, they recovered. And there are patients with, even with a lower AHI, because the breathing and the symptoms are abnormal, I went and treated them. So there is no study to show that, but the studies are variable as far as a cutoff for the babies are concerned.
And also, if a baby has a tongue tie, but also severe low tone, how do we weigh the risks of release versus low tone potential for occlusion?
Yeah, I think that has been an interesting thought, and I've been struggled with that idea, because if the tongue is also of low tone, is the tether tissue a kind of anchor to the patient? Now it depends on two things. If the tether tissue is causing feeding difficulty, other things, you may go and do like a gentle release to facilitate feeding and swallowing. But if it's not, you may want to initiate, depending on if it's a genetic disorder causing low tone, go that route and physical therapy, or myofunction therapy for baby, and subsequently a release at a later date. And again, depends on, like, do we have to cut the tongue as soon as we see the tongue tie, or wait, fix the other problems, and then take a staged approach?
Did you want to add to that, Dr. Liu?
Yeah, and also, if it's really these low tone situations, I mean, a good sleep study at a center like where Uma's at is going to be critical, right? Because you may not just have simple run-of-the-mill obstructive sleep apnea in that situation, and then you would need a lot more support. Then just remember all the stuff we're talking about here: the tongue tie release, myofunctional therapy, that is addressing obstructive sleep apnea, and really addressing only that pharyngeal critical negative closing pressure, right? That's all we're modulating. So all these other potential mechanisms contributing to OSA, let's say, are cannot be addressed by the interventions that we're talking about there. So then you're going to need help in specialized centers like that.
There's a little more information from Jess Japer. Thank you. The baby was having 18 events, but very low tone. ENT said that was a normal amount of events. Any comment?
18 per hour or 18 total?
18 events.
18 total. I think
18.
For an entire night, just 18 is normal. And again, remember, it's not about just an event. So remember, when we score an event, we don't score a duration. That one event may be 1 minute long versus a 2 second long. We still call them. So I really look into the details, the details in the devil, like what I got devil sees in the details. So it is just not the number. It is about the type of events and how the events looks. And that's the reason I put, actually, these are one of the hardest study for me to read. Even though I'm reading for 20 years, these studies, I take twice as much of time, because if I don't interpret this wrongly, either somebody will end up on a surgery which they don't need, or they may not get a surgery when they need it.
Why do babies and children have retrognathic mandibles? If the maxilla is the right size, shouldn't the mandible swing forward? Why is it small? That's a great question.
I think that can start from utero. If you're not suck and swallowing, you can be set for an abnormal jaw movement, because the jaw growth, in my opinion, depends on the jaw movements and suck and swallowing. And that may continue through postnasal period of not breastfeeding or bottle feeding or dietary habits. So it can continue. Even though you're genetically programmed to have a normal jaw, your epigenetic factors or exposure to the hypoxia or abnormal fetal movements can predict you to develop abnormal jaw.
Yeah, I think another thing to think about is when you say retrognathia, right? Sometimes as an example, right? You can have a normal size maxilla, but what's the orientation, or what's the angle, right? If it's a high-ish angle, then your mandible may not swing fully. The mandible may be the right size, but because the mandible is also going further down, and now you have the appearance of retrognathia, where the mandible is actually the right size also, but the orientation is wrong. And oftentimes that's, at least developmentally, oftentimes we do see that case. So beyond what Uma has mentioned, which is again, okay, so yeah, you do have the genetic factors and very early, gestational factors involved during development. Also, it's which direction is the jaw going, so to speak.
As a dentist practicing early interventional orthodontics, I feel the rate of symptoms of sleep disordered breathing are increasing. What are your thoughts due to epigenetics? Are we entering a new expression of craniofacial growth?
I think craniofacial is one of the factors for sleep disorder breathing. It's not the factor, but a lot of times this is the multiple factors about exposure in utero, prematurity, or postnatal, feeding practices, or not only feeding practices, even postnatal breathing. For example, if you're mouth breathing and we take it lightly, even though the patient is asymptomatic, but that is setting the direction of the jaw and the maxillary growth to a point that the airways become more collapsible, or the jaw becomes retrognathic, or the maxilla becomes narrow to the point of causing upper air resistance to narrow nose. So these are the factors in the what I call as the natal period, and can progress over a period of time. You really don't need to have sleep apnea on day one. You may be a completely normal, benign-looking mouth breather on day one, looking cute baby. Everybody loves with normal development, absolutely normal. But this is slowly sleepwalking into craniofacial dysmorphism over a period of time.
Yeah, and then let me offer also. I mean, like your question, I'll offer more of a, let's say, sociologic, socioeconomic type of explanation to add to that as well. I mean, to start, we have a lot more premature babies who are able to, grow up healthy. But part of the issue is, of course, in the early days, they have the challenges of feeding, and also a lot of their anatomy is still underdeveloped. Then added on top of that, you have the advent of antibiotics treating pharyngitis, and nobody takes out tonsils anymore. So you essentially have, and again, this is my kind of horror story model. You have these kids now born early, non-breastfed, bottle-fed, allergic to every plant and form of rock. And then the tonsils are taken out, and now they're mouth breathing with these narrow little jaws. And then they see the orthodontist, and then the premolars are gone. And now you've really shrunken it all. So there is also kind of this bigger societal picture where there's more diversity in the initial presentation. There's the change in taking and not taking tonsils. And instead of expansion type of treatment, we go to extraction and quickly align teeth. And then the entire fragmentation to a point where it's even, I don't think it has improved that much today. I've seen a lot of pediatric patients now, they come in to see me and they'll say, yeah, we're going to go see the pediatric endocrinologist. And then, he or she's about to go on growth hormones. And you're thinking, oh man, more fragmentation, right? Because the other issue might be like, if we treat the kids for sleep apnea, and they actually sleep, so growth hormones actually produced. You don't need exogenous growth hormones for these children, right? So, and that's the thing. So there's also some bigger kind of societal forces that I think push towards that way.
Dr. Liu, what percentage of patients would you say have successful expansion and still need their tonsils removed?
I don't know if there's any specific percentages, but I'll probably just mention it this way. What I do know is that the older you get, and then before you get expanded, right, the more likely you're going to need expansion and something for the soft tissue, the tonsils or soft palate. And let's think about it this way, right? How often do you think you find the person with the perfectly beautiful jaws and just, their issue is just two hunking big tonsils, and you remove them and life is great? Well, there is stats on that. It's less than 18%, because that's the success rate of UPPP at the highest level, okay? But again, how often is that? It's not, right? Because they come hand in hand, all right? It's likely the narrow, I can't breathe through the nose person situation, right? With the persistent mouth breathing and with the persistently large tonsils, that's the person. Now, when that person is 15, 25, 30, those tonsils are not just going to be tonsils. They're going to be endophytic. It's going to drag down your soft palate. Your palate-pharyngeal muscles is going to drag, and the negative pressure is going to drag everything. You're going to need to do both. The earlier you expand, and the tonsils normalize before any further maladaptive processes happen to those soft palate muscles, right? The less likely you'll have to do anything. So, I think a way to think about what you're asking is the longer you wait before you treat, let's say in cases where patients need maxillary expansion, the more likely you're going to have to do both.
Dr. Katwa, do you want to comment on that?
No, I think he said very, very nicely. There's nothing else to add. Like beautifully said.
Can you speak on mandibular expansion? I have heard orthos say it is not possible, while other airway professionals say it is. Many orthos are hesitant to expand maxilla due to this. I think that's a Dr. Liu question.
Well, I mean, everything is possible. The question is, do we need to do it and why? But generally speaking, guys, you know this, right? With the really young kids, they do like to do upper and lower jaw expansion. And quite frankly, when they're 4 or 5 years old, they're not, not painful. They do develop things. And, sometimes you maybe really need that lower arch to be expanded, if uprighting the molars isn't adequate, right? Now, I think it gets heroic when you are now 40 years old and now you're trying to do, this type of expansion. So the answer is it can be done. There are certain instances where that can be helpful. But I would just say that you're doing that maybe, let's say, to match, the upper jaw on your way to, let's say, jaw advancement surgery. Okay. It's kind of generally, if you look at the process, that's how that goes. But I would say that generally speaking, remember with the maxilla, the expansion is not just about, again, that bony structure. Right? We talked about the nasal cavity, the nasal mucosa, tongue position and all. For the mandible, it really is about orientation. If that mandible is going down, pointing down, it's just not nearly as good as is going forward and up in that counterclockwise rotation with the chin point supporting all your suprahyoid muscles. So, it's about impact, right? So for the mandible, I do think it's a lot more of a sagittal impact, whereas with the maxilla, I think it's a lot more of this transverse impact.
And how early can expansion be started? Dr. Katwa, how early do you think can expansion be started? Anything on day one?
The question is, how do you do this? I think the breast is the best expander on day one. Tongue is the best expander. So an expansion doesn't mean that you need to put a device and try to crank it up. So expansion can be done naturally. And also avoiding certain type of pacifier, which really puts the force around it and make it narrow. So more than making it expansion, I would prevent it because the bones are cartilaginous are very easily moldable in the babies. So if you really practice bottle feeding or thumb sucking or wrong pacifier use, so this, you are not giving the natural expander these babies need. And also the tongue is lying low and not able to sit on the palate. So you basically are not expanding. So an expansion starts on day one, provided that you use the right tool for expansion.
Hello, want to add to that?
Yeah, it's best expansion day one is breastfeeding, right? I mean, there's no question about it. So anything we can do to help achieve that process is great. But I think your question is more on the device and again, that's very dentist orthodontist specific. I know there are folks who will go as early as 3 or 4. I would generally say this, right? On the grand scheme of things, if the kid's really struggling right around age 2 or 3, your quickest way to solving that issue is your adenoids and tonsils. Okay. And I think that's a legit time to do it. Once you hit 4, 5, 6, you have that ability to expand and you should do it. Because you save a kid from a trip to the OR. It's always nice. They may remember that trip now, and that's not great, a great experience no matter what. That's and I think Lauren, you guys have courses that do early expansion, right?
Absolutely, Dr. Kevin Boyd's course, and then soon the Alinda and Crystal Dean Duru, they just joined faculty too. That'll be Q4 of actually 2026. So stay tuned for that. So this is interesting. There's a lot of controversy about the pacifier, and this may be an oxymoron, but what kind of pacifier is good to use? Is there such a thing as a good pacifier in your opinion?
So again, this question should be directed to lactation consultant, but when I talk to them, there are, like, in my opinion, pacifier should be like a prescription. You should not be just going to the CVS and just buy one and then put in the baby. The idea of the pacifier is basically around soothing the baby. That has led to a pacifier addiction and avoidance of the breast milk, nipple confusion, and ultimately depend on that so much that the baby is on the pacifier for almost 12 to 14 hours, and sometimes the baby sleep with the pacifier. So imagine the pressure on the pacifier is going in the wrong direction. And there are some non-nutritive sucking where the tongue actually is touching the palate and expanding. Now you put a pacifier in between, the forces go around the pacifier. So there are certain pacifiers which my lactation consultant mentions me, and they are like a little bit broader, and based on the age, some people measure the palatal distance and they recommend those things. So again, I work with them. I personally don't prescribe them because it's not my area of expertise.
Dr. Liu?
Yeah, if I weren't operating, I would be in the business of designing these pacifiers. I mean, they could be, again, as Suma was saying, right, little intraoral scan, get the right shape, get the right, stiffness. Really, they could even be great training devices. So, but yeah.
There's a scope to actually work on the pacifier. Still there are not perfect pacifier, which makes the breast tissue to the point of when the baby is feeding at the breast, if you look at the baby's latch, and when the baby is latching on the pacifier, they're totally different. And the pacifier, the round part is almost hitting the face, where when the baby is sucking, it actually impedes the lower jaw motion. It cannot bring it forward. So still there is scope.
Thank you. There are a lot of questions here on training. So I do want to share my screen on kind of what we offer at Airway Health Solutions. And again, I'm so thrilled to welcome our new faculty, and I'm still on the high of Airway Palooza, and appreciate everyone who participated and joined us. A lot of people are on the call tonight, and there will be recordings available. But let's welcome all of our faculty here, because they're really going to expand the scope of treating and provide more solutions for our clinicians. So we're thrilled to announce everyone here. I think we can put the press release up in the chat for everyone to take a look in more depth. But we want you to join us upstream, because it's not easy, right? But we can do hard things, and we can do it together. And when we have the support of a faculty like this and the community that we're building, we try to make it more easier for you, both clinically and some technological advances that we're going to tease out next time that we have our conversation. But let's talk about your course and how, we had a mastermind a couple of months ago, and I saw a missing piece in this spot from the medical dental collaboration side. And like you said, Dr. Liu, you and Dr. Katwa have been partners in crime for this for a while. Tell us about your history working together and what your goal is of this course that's going to be March 13th, 2026.
So I think, again, we have some ideas about how to do this, and I just gave an idea like what it could involve. So in this area, for me, I will start right from the conception of a baby, even before preconception, how we should think about the health of a woman, and then coming to the prenatal factors, and then the gestational factors and postnatal. We'll try to go much more details into the airway screening for babies, and what are the interventions. We'll bring certain expertise to see what is that we can do. These could be very subtleties, but these are very, very impactful. Every intervention doesn't need to be a medical intervention. Every intervention doesn't need to be a surgical intervention. There are a lot of interventions, just if you're aware and incorporate in your practice and teach parents, they can auto-correct them. So that's the whole, this is going to focus on that very, very early. And then we will also talk about how to screen them in the first year of life. So this course will cover up to 1 year from day one, from prenatal to birth, and then up to 1 year. And then there are other courses which we can talk about later in life, but I think we want to focus more on that early, where the preventive strategies have the most impact at that age.
Way upstream. Dr. Liu?
Yeah, I think for those of us who have been dedicated in this field, and whether it's via medicine or dentistry or surgery, I think it's impossible for us to not realize the importance, right, of early treatment. And again, otherwise, I mean, I thought I did a good job to kind of share with colleagues that, hey, don't create surgery, don't borrow things from other things and like try to create something. the airway is way more complex. The best you can do is to restore form, try to train the function. And then I thought, well, cool. I have a good protocol in treating adults where we restore missed milestones. But now, again, even better if we can all work together and just not miss them at all. So I think this course really begins that dialogue, and collectively, I always think that around the country, around the world, if there are little ecosystems, right? The practitioners, oftentimes these days, they are the dentists who quarterback the care of these patients. It's a great start.
Yeah, and we're thrilled. So it's going to be March 15th. We're going to have it as a virtual live, and then it'll be on demand, so people can access it at their leisure. We are offering, just going back, we're going to extend the AP code to everyone on the call tonight for 20% off of all our courses. We don't do this very often, so that can be up to $1,000 savings on some of our courses. So take a look at our website. See, I'll go over quickly some of the high level courses that we do offer, because people are asking. But the code is AP 2025, and that'll be good till midnight on Halloween. So get back from your trick or treating and look at our website to look at all the courses. Another new course is Dr. Pia Gandhi. We found that everyone's so curious about integrating laser tongue tie for these frenectomies for the tethered tissue. So that's live. You can actually register today if you want to take advantage of the 20% off. That's going to be January 9th and 23rd. And the course here is actually live. So if you wanted to save 20% off and save your spot, you can. So we just have that live. You can go to our website and look at all of these online. It's airwayhealthsolutions.com, or scan the code. So you can register for that with the 20% off. We do have Dr. Jenna Schwibner. She's actually an AHS alumni. So she just took the course in 2020, and now she's basically airway only in her practice. And she's teaching her tips and tricks of integration. So it's a very hands-on course, and we will be offering live shadowing in Vero Beach, which is lovely, Florida. So those dates are going to be coming in April. I just wanted to feature some of our basic courses with Dr. Ben Moralia. This will get you in as an Airway Health Solutions alumni, and you went to the pediatric or the adult mini residency, and then you become part of our group that supports each other and collaborates together. But here are some of Dr. Moralia's courses. Then we have Dr. Boyd's courses, who focuses on ages 2 to 6. And then Dr. Susan Maples is wonderful for team training, focusing all on pediatrics. So take a look at our portfolio of courses. And for adults, we have Dr. Gelb with the TMD. We have our new course, which was just on Friday. We have wonderful rave reviews from that about metabolic health and inflammation. That is going to come on April 17th. But the course we had on Friday was about adult laser integration to help your patients breathe, sleep, and thrive. So take a look at all of our alerts. Dr. Maria Matla is going to be doing a full reconstructive course featuring the myo-aligner, and that'll be in February 26th. So I believe that is live as well. And what a great course this is for everything we're talking about, because of all the research that you're showing. It's so important to learn just the basics of what is sleep apnea, the difference between obstructive and central. And Dr. McCarty does a wonderful job at making such a complex subject, as he says, easy for you to understand, so you can empower yourself, your patients, and have interdisciplinary conversations that you feel confident in having. So there's our flash sale. That's for October 31st. I also do want to promote upcoming courses. The Breathe and Thrive Symposium is February 6th and 8th in Vegas this year. Dr. Moralia and some of our faculty are speaking. Dr. Cohen, Dr. Jenna, Dr. Christensen, Dr. Zaghi will be there. So that is a wonderful conference, February 6th and 8th. And our next Palooza, we're announcing that we're actually going to combine these conferences. So in 2027, we're going to have Airway Palooza and the Breathe and Thrive Symposium combined together. So stay tuned for those announcements. And my friend, Dr. Gerald Simmons, his SEC conference is coming up. And I believe this is the last date on Friday for early bird registration. So this is something you don't want to miss. We see familiar faces there as well. So Dr. Liu, you're speaking at that one. So make sure if you want to take advantage of the best price, now you have it. So feel free to scan that code, and we will also send follow-up information on the SEC conference. Also, as I said, we're all board members of the Children's Airway First Foundation. We're very passionate about going upstream. Candy and Brad Sparks are the founders. They're wonderful. They're listening with us tonight. But go do yourself a favor, go to the website, check out what they're doing, look at their podcast. Chloe is a great host. I met her at Airway Palooza, and they're doing amazing things, and they're here to support you. So feel free to check out their resources and consider making a contribution for all the help that they do, especially under 0 and 0 to 1, the first year of life. So we can really go way upstream. So thank you, Children's Airway First Foundation. And for me, that's a wrap. We do have our raffle. So I'm going to go ahead and stop this and see who gets the free course, and we'll spin the wheel. And then again, your CE will be automatically sent to you with the attendance. So I'm going to have Jay go ahead and spin and see who wins our free Fundamentals Airway course valued at $800. So let's take a look and see who our lucky winner is. Chloe Appleberry. Okay, she's actually the director of CAP. So I'm going to go ahead and spin that again because she's not. That's so funny because she's just on my brain. So hi, Chloe. We'll give you something else. Maybe I'll give you an Amazon card or something. Let's get a clinician in. Okay, Renee Robinson, you are the lucky winner. So we will reach out to you via email, and we really know you'll enjoy that course as well. So let's bring it on home. Dr. Liu, Dr. Katwa, let's just give some closing thoughts. I'll have you start, Dr. Katwa, at the importance and also the relevance that everyone on this call has to make a difference. So is one thing that you could do, a call to action, would be really a great way to close out.
I think we have to switch the paradigm of how we approach the problem. I think there are a lot of people who treat sleep apnea. There are a lot of people who design surgeries, different devices to treat what we call as almost like a burnt out problem. If we want to prevent that, if we want to prevent our kids from suffering from sleep apnea, and a lot of parents have the morbidity and I think not only the dollar impact of the healthcare cost, I think the emotional and the intellectual impact of that, the reaching the potential of a child because of sleep disorder breathing, which can be easily identifiable and preventable by simple awareness and screening tools. If we can implement that and even try to make it a beginning, I think it will be a big task to completely change. It's many years away, but I think awareness among pediatricians, early dental practitioners, understanding each other's role and practicing that, I think that will be the big thing I'm looking out of this conference is to make aware. There are a lot of conferences talking about treatment. There are new therapies, newer drugs, and insurance companies are paying up to $100,000 a year to give the drugs to treat sleep apnea. So that's not the goal, and then people can design those drugs. But I think I want to go back to the basics and see if I can prevent it.
So back to basics, a lot of power impact there. Dr. Liu?
Echo that entirely. I mean, the beauty of what we're trying to achieve, on the one hand, it seems so complicated. But there are some straightforward things that have proven to be important, that as a group we can do well, and especially the earlier we start. And in this case, for example, nasal breathing. I mean, just that simple, not simple, but that simple goal in mind, that nasal breathing during sleep, to restore wellness overall and growth and everything, is so fundamental. I think there is few more impactful public health interventions that is really quite close to within our grasp. So again, excited to be part of that effort as well.
Great. Well, thank you all. Thank you both. We really appreciate your wisdom, your expertise. Welcome to faculty. Couldn't be more thrilled. And everyone, thank you for joining us tonight, because you are the change agents. You are putting this forward, and we're here to support you. So let's do this together, go upstream. And we actually have our next Airway Health Solutions conversation December 10th with Dr. Pia Gandhi. So you can go to our website, airwayhealthsolutions.com, and learn more about that. And you'll be seeing it on our Instagram. So make sure you follow us Instagram and Facebook. Thank you both again. Have a wonderful evening, and we'll see you soon, everyone.